Good morning, everybody. All right, that's good energy. Well, today is on conference day, so I hope everybody is ready to engage and interact and lead sessions and have big ideas. We're going to have a great day. But first, and I hope everybody had fun last night, I dragged a bunch of our team down to do some line dancing and then chickened out myself. So oh well. But I hope everybody had a great time last night. Our first session today is a session that I'm super excited about. This is our LIT Awards, Leaders Innovating Telehealth Awards. And our awards are really all about honoring our customers and the great things that you guys are doing to really change the lives of others. So very, very excited about this session. Our LIT Award finalists, we had a great set of nominations, really some incredible stories, and we had some great submissions. And our award finalists are Children's Hospital Colorado and the Charleston Dorchester Mental Health Center, working with MUSC, and then the Nemours Health System. So what we're going to do here this morning is that each of our finalists is going to come up, and they've got 15 minutes to share their stories. We want to learn about what they've done, learn about the benefits that they've delivered and how they have really made the lives of patients better. And then what you're going to do is you're going to vote on your favorite story. All of our award winners will receive a lovely piece of glass. It's pretty heavy. Don't worry, we'll mail it to you. We'll ship it to you. You don't have to put it in your suitcase. So what I'm going to do now is I'm going to invite our first presenter. We're trying to be as democratic as possible and go in alphabetical order. So our first presenter will be from Children's Hospital Colorado. Our first speaker is a healthcare policy educator, system designer, and entrepreneur with over 15 years of experience in public health advocacy, e-health innovation, and model development. He's currently director of ECHO Colorado, as well as the director of telehealth services for Children's Hospital Colorado. You may have met him yesterday. Please join me in welcoming Fred Thomas to the stage. You have a clicker? All right.
So they warned me this morning not to do what I did yesterday, so I'll try. In preparing for this last week, I was talking to the team, and they said, you don't have any of these compelling videos with crying people and old people that didn't have to go out in the snow. And I said, don't have any of those. So this is my 15th, 16th, 17th year, somewhere in there, of telemedicine. I've done plenty of those videos, and they go along with grants and pilot projects. And once the funding is done with the pilot project or the grant, if you don't have data that goes along with those stories, thanks for the story. So what I'm going to try to show you today is a little bit, that is a compelling story related to a topic that impacts every state in the nation. Every hospital, if you ask them their top issues that they deal with, are mental health related services and addressing that impressively. So I'll tell you also, last week I was in Washington when I was giving this, or preparing for this, and data kept coming up. So I spoke to every member of the Colorado Congressional Delegation, 2 senators from other states, the Health and Human Services Department, and several conversations. They brought up this Harvard study of last year or the year before that demonstrated that telehealth would actually make services, or people use more services. And the idea for that is they kept dragging this one study back out of the dirt relative to kind of here's what we're worried about, is this one study that they're dying for data. They want data, and that right now healthcare reform is happening, and we have the right tools, frankly, to make a move in healthcare reform right now. And so if you don't have data, get data. Work on data. So our telehealth work is embedded in everything that we do. We have approximately, I think, 125, 130 different use cases of telemedicine. Lots of breadth, not a lot of depth relative to it happening in multiple areas of the hospital. But what we look at is a little bit is like how it happens across the day of the spectrum of a patient's day in the hospital. Before they get here, do they need to be here? While they're here in the inter-agency kind of specialty consults, and then after they leave to make sure that if they don't need to be at the hospital and can get care in the community or at their home, that they stay in the community and don't have to come back too soon. So here's like a few little things, and again, I put that up there, so if you have a topic of interest you see there, you go, Fred, I want to talk to you about blank, you can come talk to me about blank. So this is the study. So what in effect is we have, it's not a perfect study, it's not a randomized controlled trial, but it is a very natural study demonstrating an impact of a program over a year, comparing non-tele, traditional as usual, treatment as usual with a telemedicine approach with the same sort of hospital setting, the same doctors, different locations, and different outcomes. So again, mental health is an issue for every state, and about 1 in 5 children have a mental health issue that they have to deal with on a regular basis, and then about 1 in 5 of those children actually get some aspect of care, and those that don't get the care that they need in their community generally cycle in and out of emergency room settings, acute related settings, and they're trying to be dealt with in a setting that's not really set up for doing comprehensive mental health care with a coordination back into the community. And so this, in effect, was an effort that looked at that it was a problem the hospital had. The prior year that we had looked at the data, we had 5 different urban locations. And if a child presented at that emergency room in those other locations, what would happen is the doctor that was there would say, we don't do mental health here. They'd call an ambulance would come and get them, and then they would schlep them over to the main academic hospital. They would wait between 8 and 20 hours, and then 52% of them would be discharged immediately because they didn't meet inclusion criteria. Not a good use of resources, not good for patient satisfaction or care, and certainly a waste of time and money for all involved. So what we did is we looked at the idea of looking at behavioral health versus traditional. We wanted to look at the quality of care, whether or not we made better transfer decisions, discharge dispositions based with telehealth. We wanted to look at the length of stay, if we could reduce that, because in effect, if you transfer them from one of these network of care locations that's less expensive real estate to an urban hospital that's an academic center that's way more expensive real estate, and you're competing for that space, it's very expensive to receive care and bad care in that space. Maybe the best care, but maybe not the care that's needed there. And then, of course, we wanted to make sure that we were looking at whether or not, you can reduce costs by not giving care. So, that's the most efficient way, right? Is basically you don't spend any money at all, and people die, and they go away, and you don't provide care. Anyway, that may be the Republican plan, frankly. But in effect, really, you kind of have to look at this exchange rate relative to, are you reducing costs, maintaining a level of care that's satisfactory or better, and then having better outcomes. And so we wanted to look at all those sort of things. So here's our takeaway. So in 1 year, we looked at a pretty good N. It was about 500 N. And what we did in the year is basically reduce the transfer rate by more than 50%. And so that alone accounted for about $402,000 of ambulance rides for the system. That is just sort of one of these things that happens along with the change of the practice model. $402,000. And so here's another one of the takeaways. So if you're a parent and you're dealing with this horrible time that generally happens at 11 o'clock, 12 o'clock, 1 o'clock, 2 o'clock in the morning, and you have to go to the emergency room, and then they say, we're not going to treat you here. Get back in your car. We're going to take your kid, strap him down in an ambulance, and we're going to take him over to the other emergency room. You need to drive over there and wait. Bad thing. So if you look at this data right here, what you see is the traditional care. Most of the people live down there beyond 12 hours, 12 to 20 hours, 20 hours plus. And if you look at the telemedicine efforts, most of the people live between 0 and 8 hours. So in effect, what you're looking at there is a dramatic change in the amount of time it took to provide adequate care. And this was published a couple of weeks ago in Psychiatric Services, and you can find that journal article. Again, if you do this in a way that people say, holy crap, we did save time and we saved money, but I really hated it, that's also not a good value proposition. So the idea that we actually improved from 72%, which is the satisfaction level for traditional, to 97%, either satisfied or very satisfied with the type of care, is a dramatic change also. And then here's your big takeaway. This is what people want to hear about. So in effect, what we did is we changed the pathways of care and just changed it and made it more practical. So if one pathway of care was, if you're this child that's presenting in the emergency room at this other location, you get in an ambulance, you come to the main emergency room, they're going to admit you, they re-triage you, then after they decide that you're going to be admitted in inpatient, then they transfer you again to the inpatient ward. Well, a change in pathway would be, if you're going to be admitted, we do the triage at the less expensive space, do all of that, move information, not people, and then they make the decision that they're going to admit them, and they transfer them once to the inpatient ward and saves a whole lot of money and time and effort. The other big savings, obviously, is the ones who don't need to be admitted and don't need to wait for 20 hours could be discharged from the network of care location. So this, in effect, is what we did, an incremental cost and time saved per encounter. And what you want to look at there is that you want to look at anything here in the low and away area, the strike in the lower right quadrant would be it saved time and it saved money. So anything here would be it costs more and it took more time. Anything here would be it costs more but it took less time, but in fact and right here would be it took more time but it saved money. So in effect, every one of the pathways that lived here were pathways worth adopting, so you could look at every single pathway, save money and time by using telemedicine. So in effect, here's the big point. So the cost to establish telemedicine at 5 network of care sites was about $222,000. That included all the operational costs, all the fixed costs, all the variable costs of my time and all of our team doing all the training aspects, all the training of the doctors and everything, divided by the number of visits and the proportion of the visits that psychiatry was of the total visits for the hospital. And then so you have the average cost savings per patient by converting, which is $1,977 per case, and you divide the $222,000 it took to establish it, and what you have is you have a break-even point of 116 patients that it took to establish telemedicine in that section. So what this is, in effect, my friends, is an argument to another group of people for the C-suite to take to them and say, this may not be your perfect case example, but we're coming to you next, and here's how we're going to do it. So let's convert the ones who don't need to be here to telemedicine. So where are we going next? You heard more about Echo, and I have a 1minute and 22-second video at the end of this, so I have to save at least that time. So in effect, what we're doing is like trying to combine all these different approaches. The in-person care, because we're not going to change in-person care, some aspect of care needs to happen in person. If you took this example, would be if you have this child that has a primary care doctor out in rural wherever, and they have this rapid cycling bipolar disorder that periodically kind of throws them off the loop, and they end up in the emergency room. What you want to do at the end of the day is you want to, instead of having them continually cycle through the emergency room, is you want, when you get back to that primary care doctor's office, you want the primary care doctor to be trained related to what to be looking for the presenting factors that say, in 2 days, they're going to be back in the emergency room. Another day, they're going to be back in the emergency room. So what you can do via telemedicine would be able to have the care done by that psychiatrist in the primary care office, so they're sharing the decision-making about that. And then as this primary care doctor out there is dealing with more diabetics, more asthmatics, more different kids with different chronic health issues, they sit in echo sessions and learn more about how to manage more of these things on their own. And so the idea is you give them more capacity to do more in the primary care space. And then the idea also would be if they, in an echo session, the panel at the university says, you're way off on your formulary there, they could pull them into an e-consult directly and talk to them about changing their formulary or changing the prescription or whatever. So it's a sort of an accordion of care, if you will, sort of a waxing and waning of an approach that you could use to help manage conditions better. So what we're doing with our own money, and they were saying earlier the people with the biggest budget may actually have a, anyway, we won't make that our argument. Anyway, but we're using a lot of money to do this. So we've spent about $8 million on developing these issues or these topics. And what we're actually developing are approaches that use each of these different tools with partners that are meaningful partners in the state, Medicaid, the foster care group, Denver Health and school-based asthma and different management sort of things like that, and topics of interest, asthma, diabetes, mental health, concussion, different things like that, that are managed in a way so that we're trying to demonstrate through these pilots a evidence approach of a value-based care delivery model. And so, again, without data, a lot of this sort of stuff goes away. So what we're actually trying to do is actually put together the right sort of studies to demonstrate with data that we have a compelling argument about a new delivery for healthcare, and that might be used as one of the arguments for healthcare reform that is not just give them less care, they'll go away. It's more like give them the right care at the right place at the right time, and reduce cost and increase access. So what I have here is a little video that we put together. It's little bobbleheads, no crying old people, no sad little young people. It's bobbleheads because I needed to be appropriate relative to the right use of color and gender and identity, etc. Anyway, so we're going to show this and see what you think.
There are many inefficiencies in the healthcare system. For a patient needing healthcare, these inefficiencies can create unnecessary treatment barriers for patients, diminishing their experience and negatively affecting their health outcomes. At ECHO, we see this as an opportunity for improvement. We connect health professionals from different communities with a variety of knowledge and breadth of experience and allow them to share best practices and resources to improve the quality and efficiency of healthcare. ECHO, one part of a bigger practice paradigm. Together, we want to make the inefficient efficient. With coordinated care, a decreased need for in-person appointments, and an improvement in overall healthcare value. By empowering the integration of the practice paradigm into the patient-centered medical home and medical neighborhood, we can optimize talent, techniques, and technology. Shared knowledge from specialists and experts creates opportunities for other providers and staff to practice at the top of their ability, increase capacity, and efficiently manage complex care. With your help, we can institute a new, efficient practice paradigm that optimizes patient experience and outcomes, lowers the per capita cost of healthcare, and improves the work life of our tireless healthcare providers. Knowledge held by one has the power to change lives. Knowledge shared by many has the power to change the world. A better life for patients and providers starts here. Let's ECHO.
So, thank you. I appreciate that. My time is up.
Oh, that was great. And I can tell you the reason that Children's Colorado was selected was because of the evidence-based approach. And I think in this industry, right, we struggle to prove the benefits and drive adoption across North America, across the U.S. and also in Canada for what we're doing. And so I think that the fact that you have built that ROI model and that evidence-based data is exactly why you were selected as a finalist. But a question for you, in terms of what do we collectively need to do, everybody here who has a program, runs a program, what should we collectively be doing to really do more of what you've got here?
Collect more data. Demonstrate that there's an impact. And one of the areas of increasing access is all good and fine, but if you increase access and it costs more, the current people who are making the decisions about healthcare reform don't care about that. It's got to provide the same amount of care with at least the same amount of satisfaction, costing less. And so that's where we need to be right now, I think, frankly. So
this might be a great unconference topic as well. And one of the things that Mark talked about in his presentation, analytics, monitoring. We want to do more also to help you get the data that you need.
Are those waters for us?
They are. Would
Okay.
you like them?
I'm going to go get one. Thank you.
There you go.
Okay.
Thank you, Fred.
Okay.
Okay. Our next speaker is the Director of Special Operations for Charleston Dorchester Mental Health Center in Charleston, South Carolina. She is trained as a crisis negotiator and serves as a program manager for several divisions of service as CDMHC. It would have been easier to just say Charleston Dorchester Mental Health Center because I actually got that, including emergency services, forensic services, and the Tri-County Crisis Stabilization Center. Please welcome Melissa Camp to the stage. Thanks, Melissa.
$43.8 million. That's the number of adults in the United States estimated to experience a mental illness over the course of a year. 1 in 8 of which will go to an emergency department for their symptoms. 3,193. That's the number of psychiatric emergency calls received by Charleston County EMS last year in Charleston, South Carolina. 80% of which get transported to the local emergency department. So my name's Melissa Camp, as she said, and I work for the South Carolina Department of Mental Health, I'm stationed in Charleston, South Carolina. And today I want to tell you about an exciting new project that we started about 6 months ago that I believe puts us on the cutting edge in the world of emergency mental health treatment. So in Charleston, we have a problem that I'm sure none of the rest of you guys have, where our emergency rooms are constantly overwhelmed with behavioral health patients. That doesn't exist anywhere else, right? No, that's just us. And so through the years, we've done some things to try to address that. In 2007, we started a telepsychiatry program that's been really successful. As Michael mentioned yesterday, our state is relatively rural, and there were ERs where people were waiting days to get an evaluation by a psychiatrist, which is just completely unacceptable. And so now we're able to use telepsychiatry to get those folks evaluations within hours instead of days. And that has been really successful and gets those folks connected to care. We also, about 30 years ago, created a mobile crisis team. So we, for those of you that don't have mobile crisis, it's a 24/7, 365-day-a-year program, emergency response team that will go out into the community and respond to those in crisis. So they will provide the same kind of mental health evaluation that you get in an emergency room, just on site. So my team will go anywhere, though. We go to the airport, the side of the road, somebody's house, the local library, any of that. And that team was developed to try to divert people away, behavioral health patients away from the emergency departments, because it just isn't a great outcome for them. And mostly because the emergency department, they have to be equipped to serve so many things that it's just not an ideal location for a behavioral health patient. There's not always somebody who has adequate training or time or resources to do what they need there. So mobile crisis has been invaluable to our community to be able to divert a lot of those people away from the emergency department. But despite us having that for 30 years in Charleston, we still have the same problem everybody else has, where our EDs are overwhelmed with behavioral health patients. And so as we got to talking to our folks at Charleston County EMS, we started talking to them about what was happening that they weren't utilizing mobile crisis more. So we only, on average, get about 4 or 5 calls a year from local Charleston County EMS. We get police calling us all the time, family members, community members calling us, but EMS only called us 4 or 5 times in a year. And as I said, they had like over 3,000 calls in a year. And basically what it boils down to is our county is long, so it's like 100 miles from end to end. And My mobile crisis team, we don't, much to our dismay, we don't get lights and sirens and get to speed through traffic. We have to go the same as everyone else. And so sometimes response time can take 30, 40 minutes to get on scene. And EMS just simply doesn't have that time. They can't tie up an ambulance sitting there waiting 30 to 40 minutes just for us to get there, and then for us to start our process to assess them and connect them to care. And so it was faster for them to just throw that person in the ambulance, take them to an ED, drop them off, get back in service for medical emergencies. So that made sense to us, and one of the doctors with our local EMS, this is about 5 years ago now, said, you know, it would be really neat if we could use telehealth somehow to connect mobile crisis to EMS a little bit more quickly. But at the time, we were still very thick into the throes of what our telepsychiatry looks like, which it requires a lot of equipment, specialized equipment, and stable endpoints for everything. And so we believed that we were going to need a pretty sizable grant to make that happen, because unlike Fred's group, we don't have any money. We're a state agency. So we started looking for grants, and we partnered up with a gentleman with MUSC, who is a forensic psychiatrist technically, but he was helping us find some grants that we could apply for. And in 2016, we applied for and were awarded a telehealth grant through the South Carolina Telehealth Alliance to implement this project where we were connecting EMS and mobile crisis via telehealth. Over coffee one morning at a Starbucks, I met with Michael and Wendy, and we mapped out what this workflow would look like. I'll be the first to say I had no idea that video even existed prior to that. And so I'm grateful forever to Michael and Wendy for bringing that into our worlds. And Michael said, I think this is going to be a really good fit for you guys and for your program. And so we'll talk a little bit about why that's a good fit for us. But first, just so you guys can get an idea, I want to show you this video so you can see what this process looks like for us.
It's a sector of the population in need of help that oftentimes ends up in the wrong place. We're talking about people with mental health issues or addiction. Routinely, EMS units are dispatched out to help, but without a means to address the core problem.
In the past, EMS has had really two alternatives. We could either release them to law enforcement for transportation to prison or to jail, or we could transport them to the emergency department. Beyond that, there was really no other options for us, and our focus was really what kind of treatment do we give people in the back of the unit, as opposed to really where do they need to go as the most appropriate treatment for them.
Today, a new multi-agency collaboration has taken the crucial steps towards a solution for those in need. It's called Telepsych, and it's designed to keep mental health and addiction patients out of the jail and the emergency room.
It helps address the root cause, helps address their mental health and substance use disorders, and it doesn't have them in an emergency department or in jail. And then that also directs taxpayer dollars, resources where they need to be. Officers can get back on the street faster. Our emergency vehicles can be back out on the streets faster so that they can address community concerns that are more emergent.
Here's how it works. Dispatch receives a call for assistance and routes EMS. Paramedics will first clear the patient of any immediate medical needs and contact a duty supervisor in a quick response vehicle so the ambulance can get back out on the road. Next, a member of the mobile crisis team is contacted.
Once they determine that a person doesn't need primary care services, to then call a supervisor out to the scene who has a program called Vidyo in his SUV. And then he can bounce back to mobile crisis, which is our emergency response team, to have that patient immediately evaluated for psychiatric needs while the EMS is on the scene. And they don't have to wait for anybody to come out. They don't have to transport the person necessarily to an ER. They can have the assessment done immediately on scene.
While I'm one person standing here, I could really, realistically, if I'd invited everybody that's a part of this collaboration, have this entire stage full. So that's a huge piece of what has made this a success, is we had to have everybody from multiple agencies in our community on board and willing to try this thing out. And And so using video, we've been able to cut our response time from maybe 30 to 40 minutes to like 5 minutes. And that's been huge, a huge time saver in our area. Why Michael thought that video was a good fit for us. So with our county, although the city of Charleston is great, with our county being so long, we've got some more rural areas where cell phone or cellular reception isn't great. Bandwidth is limited, and so the fact that video can accommodate for that and adjust for the bandwidth fluctuations was without interrupting the provider's ability to do the assessment was a big deal for us, and has made a huge difference because we've got EMS vehicles out in the middle of Nowheresville trying to connect to us, and we need to make sure we're providing good quality care. The other thing that's worked well with us, since it's mobile crisis is a team of people who are on call 24/7. EMS, it's different supervisors who are out different times. Video's meeting rooms afforded us the option of you don't have to know the name of who you're going, and try to find them within the directory to meet with them. We have mobile crisis meeting rooms, virtual meeting rooms on there, and we're able to just connect into that room and provide the assessment. So that cuts down on a lot of complications that would ordinarily be there. So quickly, some results that we've had. Again, we've been doing this, we started at the beginning of May. So we're right at 6 months now. The data I've got goes roughly through about 5.5 months worth of time. We had approximately 4 to 5 calls a year from EMS prior to this. In this first 5.5 months, we've gotten 316 calls. We expected the program to be successful, but not quite like this. So one lesson learned really quickly is we first got set up with one room, one little virtual meeting room, and very quickly I was like, Michael, how quickly can you get me a second room? Because we had multiple assessments going on at the same time. And keep in mind, this is just them calling us on low-level calls with no medical emergency to it. So they get roughly, I think they estimate around 12 behavioral health calls in a year, in a day, in a year. And they're only calling us out on the low-level calls. And you keep in mind, before the stat I said was 80% were transported to the emergency department prior to this program. Since this program, we've been able, with the calls that they've given us, we've been able to divert 54% of those from the emergency department. It's a pretty substantial number for just getting going. 47% we've been able to divert from the hospital. So we can connect people to outpatient providers, different things that they may need in the community. We may be able to de-escalate a situation while we're interacting with them via telehealth to where they don't need to go anywhere. But we also have great relationships with our local hospitals in that they will allow us to get folks right onto a psychiatric unit and bypass the emergency department if mobile crisis is the one assessing them. And then this stat to me is the most profound. So only of those calls that we've received, only 13% of those have resulted in the person still needing to be transported to the emergency department by EMS. So that's a substantial decrease from 80% to 13% in just 5.5 months. And keep in mind, the first week or so of that was just us trying to figure out what direction we were going in, and remembering that we trying to figure out everywhere you went when you were on call, you had to have access. So the dollar amount, as Fred was saying, that's what our leadership wants to see. That's what county council wants to see when we look at continuing a program like this, because in our state we can't bill for the service via telehealth for master's level clinicians. So we base this on approximate cost of $350 for an ambulance ride, which anybody who's had to pay for an ambulance ride knows that's a low ball figure. And $2,000 for a very, very basic psychiatric ER visit, again, a low ball figure for most. So in the data we've collected based on those estimates, we estimate that in this 5.5 months, just in Charleston County, just with these low-level calls, we've saved the system a little over $419,000. So that's huge. To me, I look at that amount and I think this is what we're saving the system, because a lot of these folks are unfunded. So that's numbers that we're paying attention to, we're providing to community partners, because we need for them to know the hospitals would be eating those costs otherwise, realistically, because a lot of these unfunded folks, they can't afford to pay for the hospital stay. And so when we look at future applications, obviously our leadership is really interested in that. So a couple of things to know that are going on in our state. While we've had mobile crisis in Charleston County for 30 years, it doesn't exist anywhere else in our state. And then this past year we got awarded some money by the Department of Health and Human Services to create mobile crisis statewide. So that's great, and that's underway and happening right now. But realistically, in some of the more rural counties, it's not doable to have, doesn't make sense for somebody to be responding in person always, because the response time would be pretty extended in some of those counties. So telehealth is really what we're looking at as far as how we take this program and blow it up across all 46 counties of our state. That will be how we do mobile crisis in some of those areas. And so we have 106 emergency transport EMS agencies in our state. And so that's a project that I've been given the responsibility for, is to figure out and do the research of what that would look like and how we would make that happen over the course of the next year or so. Which you can imagine the money savings is pretty substantial. And then I'm out of time, but I do want to say one last thing. The other piece that we're looking at is putting it with law enforcement. More and more we hear, if you know anybody personally who's an officer, you know that law enforcement is called upon to make some decisions on mental health issues on a regular basis with very limited training for it. And so one of the aspects we're looking at is, because of the ease of how video can be plopped onto their laptops, most agencies, their officers have laptops in their cars, that we could connect mobile crisis to law enforcement to help them in making some of those decisions in our community, so that we keep our community safe, we get people connected to the care that they need. And so it's exciting, and if you couldn't tell, I'm pretty passionate about this stuff. It's exciting time to be doing this kind of work, and I really feel like as we talk about healthcare reform, this is what we're talking about. This is where we're headed, and so I'm excited to be a part of it. Thank you, guys.
Thank you, Melissa. That's a great story. I just do want to reinforce that point. So it was $419,000 in savings, one county. There are 46 counties in South Carolina. So I know it's not quite as simple as a basic extrapolation of that number, but that is a really significant savings when you take it across the entire state.
Yeah, it's exciting.
Yeah. The other thing that I found really compelling about your submission was the fact that you were coordinating across a number of different agencies. Can you talk just a second about the challenges or lessons learned associated with making that work? Breaking through the red tape?
Yeah, well, I think the biggest thing has been that we had pre-existing relationships with a lot of these folks. Yeah. So we work really hard to keep great relationships with the partners in our community. And so that was huge, and just keeping that communication open. So we've been going for 5.5 months, and we still have almost every Friday at 9 a.m. a phone conference between EMS and mental health and anybody else that needs to join in on the call to discuss what kind of problems did we come up with that week, or how can we tweak this and make it better. And I think that communication is huge. Yeah. And that's been the leadership. My executive director has joined those calls on occasion. Their medical director, their director have joined those calls, because it's just that important to our community.
Great. Okay. Well, thank you very much. Great story. Okay, and certainly last but not least, it's last in the alphabetical order, our next speakers are from the Nemours Children's Health System. We've got a duo here. The first speaker is the telehealth leader for Nemours, Delaware Valley. He has served in healthcare for over 15 years and was one of 3 people who started the telehealth program at Nemours. That's Jeff Barnello. He will be joined by Senior Telehealth Technical Coordinator from Nemours Care Contact, the telemedicine program for Nemours Children's Health Center. So please join me in welcoming Jeff Barnello and Colin McQueen. So Colin, you're based in Florida. Thank you.
Thank you. All right. Thank you very much. Yeah. So I'm Colin, that's Jeff. I'd like to thank Fred and Melissa, and we're honored to be up here sharing the stage with wonderful organizations. To get started, I'm going to tell you a little bit about Nemours and who we are. So we're a nonprofit health organization devoted to children's health. We're funded off the enduring legacy of Alfred I. DuPont. And after DuPont's death in 1935, he left the bulk of his estate to the care of children. So following through with his wishes, the foundation built the Alfred I. DuPont Orthopedic Institute in 1940. And then later in the 80s, that was transformed into the Alfred I. DuPont Hospital for Children, which is where Jeff is located in Wilmington, Delaware. And then in 2012, we opened a second freestanding hospital in Orlando, Florida, Nemours Children's Hospital, which is where I'm located. So to give you a little perspective, we have about 400,000 patients we care for throughout our health system. Our mission is to transform how healthcare is delivered by leveraging technology and increase access and improve outcomes, very similar to what most of us in here are trying to do. What we call our true north is really our mission statement, which is help me receive exactly the care I need and want, how and when I need and want it. Again, very similar to what we're trying to do, and I think everybody else out here is trying to do. So those are the metrics we strive for. Obviously, we do not meet those. That's just always the goal. But telehealth fits perfectly into our mission and goal and vision. Our comprehensive program is called Care Connect, so that's really what we named our entire program, telehealth program. Very similar goals is what we try to do, improve outcomes, leverage technology to meet demands of today's families, ever changing, especially with the millennials. The people are expecting this technology to care for their children. So I'm going to turn it over to Jeff. He's going to kind of talk about where we started and dive in.
Thanks, Colin. Thanks, everybody. Just real quick, kind of where we started, not unlike a lot of people that are in here. We looked at critical care consults. We looked at referring hospitals in the Delaware Valley and in Florida, and where we could, make some impact. So we looked at critical care referring pediatric referring hospital, adult referring hospitals. We looked at the delivery of pediatric specialty care, specifically to our underserved areas in southern Delaware and some of the rural areas in Pennsylvania. We implemented all of this within 60 days, and after success, we moved on and looked at things that we would do in the region in Florida. So we talked about why critical care consults. It's a simple implementation of leveraging technology, but a very important one. Improved patient outcomes for our most complex kids. As we went out and talked to these community ED physicians, and we talked to them about what would happen when you guys get a really complex or a child where you're, kind of not understanding of how to treat this kid. The first thing to do is just pick up the phone and call our transport line, and we would just come get them. And that in of itself is very inefficient. So we looked at reducing the number of unnecessary patient transports, keeping them in their medical home, and then also at the same time streamlining our intake process so we knew what patients we were getting and where they would go to. So some kids didn't sit in the ED for hours. Some didn't end up in our ICU with a larger level of care when they actually needed to be in a lower tertiary floor unit. So where are we now? We have iPad carts in more than 60 locations located all over the 5 states in which we serve. We have these consults broadened into specialty care consults, into emergency rooms, into NICUs, and PICUs, and inpatient floors, private PCP offices, and even cruise ships. We looked and saw a sharp reduction in unnecessary transports. I think the number was just a little bit above 33% before we started, and is now below 9% or now below 10%, so somewhere between around 9.3%. If you look at the average of 3,000 to 7,000 per pediatric transport, we're saving, just like Fred and Melissa talked about, an enormous amount of money, an enormous amount of tax on our healthcare system, not to mention the things we can't measure. quality of life issues with a family who gets uprooted in the middle of the night, ends up 3.5 hours away in one of our EDs, and then turned around because it was completely unnecessary. So this is where we're at. We're also increasing the efficiency and the comfort for these small rural adult facilities for treating and caring for some of these kids. And we're starting to see that really pay off. We've got well over 1,000 consults in about 2 years, and quite simply, it's making a difference. So then we talk a little bit about the delivery of pediatric specialty care. There's a large number of no-shows and cancellation rates where patient base in rural and impoverished area of southern Delaware, I know people are talking about Delaware is really, 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 really small. We know that, we get that, but also Delaware only has one road. If you've ever been on it, we apologize in advance. If you're going on it anytime soon, we're sorry. There's one road, it takes forever to get from one end of the state to the other. And so with these rural areas, it's important that we take care and bring it to them. Because we've seen over time, they're not coming to us. Whatever care they need, if they didn't get it in their community, they weren't going to get it. And I think over time, you'll see the negative outcomes that will have. So our mission and our goal is to bring care to these kids and to these families. Increasing quality of life, and then better clinical coordination between these multidisciplinary visits. And at the same time, we're optimizing care, allowing for more patients to be seen. I think we've seen some studies that we've done, some of our physicians have done, where remote telehealth visits have actually saved an amount of time for our physicians, allowing them to see a lot more kids. So where are we now? Over 27 pediatric specialties deliver a form of telemedicine in one way, shape, or form. As Colin shared with you earlier, we're around 748 physicians. We have well over 300 physicians trained and have done some level of telehealth and telemedicine visits, and we're very proud of that. That is a very big number for us. Partnerships with 6 private PCP offices. So basically, kids of these private PCP offices, they go there, they go to their medical home, and we deliver specialty care to them in things like endocrinology, weight management, nutrition, psychiatry, psychology, and I can go on for almost 20 more. But if you look at the outcomes and what that's doing and having an impact across the board. We're lucky in Delaware, we have patient parity, we're getting paid. Not necessarily so in Florida, but we have taken advantage of that so that we can deliver care in the best way possible. And our demand for these remote specialty partnerships is high. I get a phone call every week from all sorts of different states. Hey, can we partner with you? Can we partner with you? It takes time. I think by the end of this year, we'll be at 8. Our contract for what we want to do and where we want to go leads us to about 10 by the time 2018 is over with. So where are we now? We continue to expand in our direct-to-consumer offerings beyond online urgent care. We do that as well. We leverage our direct-to-consumer services for disaster relief. So if you look at what had happened with Hurricane Irma in Florida, we work closely with the Department of Health on disaster recovery plans in the state of Florida. We'll also be looking at that for the state of Delaware. They've reached out to us and said, hey, we need to start having this conversation. We deploy carts to emergency relief disaster centers in the airport for refugees and things of that nature. And what we've seen was a substantial increase in enrollments and visits during these natural disasters. And here we are, where are we with the delivery of pediatric specialty care? It's part of our community health needs assessment. We've seen a large reduction in no-show cancellations rates to below 10%. That's at 9.1%. That's a huge deal. It is a big staff issue with the large amount of no-shows and cancellation rates that happen in the pediatric realm. We also partnered with Press Ganey to pilot a telehealth specific satisfaction survey, and we're very proud to say that we're in the 98th percentile. It's 89.7% likely to recommend, and that puts us, telehealth offerings, at the highest of all Nemours health systems. So we're very proud of that. And reimbursement across the board is above 75%. So what's next? It's a little snippet of what we're doing, where we're headed, integration with people like Echo Stethoscope and Tidal Care. We're growing our specialty, and we continue to look at the cost savings and the quality of life savings and the impact that telemedicine is having. And we're looking into getting into the remote patient monitoring world for our complex patients. So what have we learned? I think this is important for me. Telemedicine is not the next fad in healthcare. I think we all know that by why we're all here. It's just not. It's how we deliver care. This is an additional tool for Nemours and how we deliver care to our families because they deserve and need it. Telemedicine is embedded into the culture of care delivery in our organization. We have complete buy-in. And that, I think, is important as we continue to drive. Data is a great thing. And although we don't have all these great data numbers to show you, I think what we would impress upon all of you is that because we are growing and that we are a larger team than the 3 people that we started off with, that shows the data there that we have proven that this is making a difference. And quite frankly, it has a profound impact on the patients and families we served. So telemedicine does make a difference. Everyone in this room knows it. I'm going to share with you a story of Talon, and I'm not going to say his last name because I always butcher it. But Talon is at the time, a 3-year-old young man who was doing everything that 3-year-old boys do. Outside, running around, loved tractors. Unfortunately, one day, Talon found himself in the arms of his father with a 90% evisceration of his abdominal cavity. For those that don't know what that means, he was about 85% cut in half. And so it was an amazing story. I can't really show just the power of what telemedicine can do on this next short video, but what I can tell you and share with you is I watched it. I happened to be in our ICU at the time, and I watched the power of this multidisciplinary team from our group and this small rural community hospital get together to save this young boy's life. And so for me, this is just another example of all the great things that we're doing, not just us, but quite frankly, all of you. So we want to share this video with you.
A quick trip to the backyard to mow the lawn can be life-changing, as a Phoenixville family learned when their 3-year-old almost died. Eyewitness News reporter David Spunt has the story of how a devastating accident sent a local mother on a mission to bring awareness.
I'm trying, but sometimes it doesn't stay.
The relationship between Dr. Sudha Raman and 3-year-old Talon Wollstonholm is a special one. To put it plainly, she saved his life. Back in May, a family member was mowing the lawn on an industrial-sized tractor when Talon ran out from behind the bushes and was run over.
In my wildest dreams, I didn't imagine that I'm going to run into a dad carrying his son in his arms, completely, filled with blood.
Raman is the medical director of Nemours DuPont Pediatrics at Phoenixville Hospital and operated on Talon minutes after he arrived. He was almost cut completely in half. Dr. Raman was able to help Talon thanks to an iPad and technology called telemedicine.
It's a secure way of obtaining expertise at a moment's notice.
About an hour later, Talon was in a helicopter on his way to DuPont in Wilmington, where he underwent a 9-hour surgery. He continues to come back to Wilmington for therapy with his mom, Alicia Wolstenholme. She still thinks about that day Talon was run over.
My first reaction was I thought he was dead.
Wolstenholme tells Eyewitness News her son has defied all odds.
It's a miracle. The angels are with him that day.
He saves the day.
Talon's case, unfortunately, is common. According to the Consumer Product Safety Commission, more than 17,000 kids and teens are injured each year in similar accidents. That's almost 50 a day. Wolstenholme wants to see more safety information available to the public. She's already started a public awareness campaign, hoping to save other kids from her son's fate.
You go out, you want to mow your lawn, you want to get it done to spend more time with your family, but you don't realize what, the ramifications of it can actually be.
Alicia Wolstenholme reached out to U.S. Congressman Ryan Costello, who told Eyewitness News in a statement, there needs to be more public awareness about little kids and heavy machinery, especially lawnmowers. Wolstenholme hopes to meet with the congressman soon to continue to bring attention to little kids and lawnmower safety. It's really amazing just to see how well little Talon is doing considering those injuries. It's only been a few months. We are live in the SAT Center. David Spunt, CBS 3 Eyewitness News.
I was going to share with you just this other little video of Talon. But I know we're out of time. But what I will say is that we still remain in contact with Talon's family, and we still use the power of telemedicine and technology to follow him through PT and things of that nature. So it's a great story. It's a great use case, and it's wonderful that we are able to and have the trust and buy-in of an organization to simply leverage technology to make a difference. That's what our organization exists for, and that's our guiding purpose, and that's what we do.
Thank you.
So thank you.
You guys want to see the video? Yeah. Let's look at it.
It's really, really, really short. So,
that was worth seeing.
Yeah, Talon wanted us to share that with all of you, so thank you.
Yeah, that was definitely worth seeing. Knew it was short. So thank you guys. Now the reason when we got the Nomura submission, we had to haul it out of the truck because it was it definitely won from the fact that it was the longest submission. No, but what you guys have done, and I think what you shared besides the Talon story, which is really an incredible success story, life-saving story, but what I think is really interesting is the fact that you talk about telemedicine, as Jay Sanders said yesterday, it's just medicine. It's woven into the fabric of what you do. So if you could just spend a second talking a little bit more about what did you do to make that happen?
I think it was about, just the power of getting people to understand and leverage technology that we use every single day, whether it's at home or in the school, and having those conversations. And we're an organization where we take pride in, we let our clinicians make choices and decisions. And our job is to empower them and to give them the tools. And I think it's a matter of just having great communication and good interpersonal skills and establishing relationships with our clinicians. I think Colin will agree with that. We like to go out and have relationships and conversations, and in that way, it helps as we look at trying to change the paradigm of treating patients that we've done for hundreds and hundreds of years.
So you're out there, you're meeting the physicians, you're finding your champions, you're getting them to help
absolutely
drive the awareness. Okay, great. Thank you guys. Thanks very much. Okay, 3 fantastic presentations, I thought. Hopefully you agree. And now it's in your hands. So here's how we're going to do the voting. Everybody has a phone, right? I need to get mine. But everybody has a phone, right? Of course. All right, so here's what we do. This is very, very simple. It's just texting, no app downloads or anything like that. So the first thing you need to do to sort of make the polling system aware of you is you need to text @VidyoHCS, just as you see here, to this number, 855-910-9662. So let's do that together. The audience winner was Charlton Dorchester Mental Health. So congratulations. And we will get you a so congratulations to you, and congratulations to you all.